Good evening. I'd like to welcome everyone to the COVID-19 Boosters and New Therapies, What's New, What's True webinar on October 6th, 2021. My name is Donald Moore, and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format for this webinar is 45 minutes of moderator-asked questions of panelists and 15 minutes of Q&A from attendees asked in chat, as all attendees are muted. Attendees who will join by telephone who have questions should email their questions to eprtraining@vdh.virginia.gov. Your feedback is requested. Please complete the SurveyMonkey survey provided in chat. It will be emailed to all attendees as well. Also, this webinar has been approved for CME and CE credit. Those seeking credit will need to complete the same SurveyMonkey evaluation, which will ask if you are seeking CME or CE. This webinar is being recorded and will be made available following the webinar. As required, because this is a CME approved event, there were no conflicts of interest to disclose from neither the planning committee members nor the panelists and moderator. Additionally, there is no commercial or in-kind support to report for this activity. Your panelists and moderator are as follows: Dr. Tyson Bell, Assistant Professor of Medicine, Divisions of Infectious Diseases and International Health and Pulmonary and Critical Care Medicine, University of Virginia School of Medicine. Dr. Gonzalo Behrman, Professor and Chair of Division of Infectious Disease, Richard Wenzel, Professor of Internal Medicine, Hospital Epidemiologist, VCU School of Medicine. And Dr. Alexis Page, COVID-19 Vaccine Pharmacy Coordinator, Virginia Department of Health. Your moderator is Dr. Alan Dell, Seymour and Ruth Perlin Professor of Medicine and Health Administration, Assistant Vice President of Health Sciences for Interprofessional Education and Collaborative Care, VCU School of Medicine. I'll now turn it over to Dr. Dell.
Thank you, Don, and thank you to all of us for joining us this evening. Let's dive right in with a question for Dr. Behrman. So, Dr. Behrman, can you sort of set the stage for us by telling us the status of the pandemic in Virginia?
Well, the pandemic is still, unfortunately, very much a reality in Virginia. Although the case rates are going down, there is still an ongoing surge, or I would say a preponderance of cases really in the unvaccinated individuals. So that's really a bit disheartening. There are cases of breakthrough infections. Fortunately, these breakthrough infections are few, and they tend to be relatively mild and generally do not end up hospitalized or in the intensive care unit. So whether it has been some improvement over the last couple of weeks, this is far from over.
Great. And as we understand it, this is sort of being driven by the Delta surge, the Delta variant. So Dr. Bell, as we think about sort of maybe this current surge waning, as Dr. Behrman said, maybe we'll sort of see, are you worried about other variants on the horizon? Are there other sort of things to make us think, okay, there's going to be a next surge after this, or how do we think about the future in terms of those variants? I think you're muted.
I think I know how to do this by now, seriously. But the nature of the pandemic has really been waves of the virus or a variant of it surging, or receding, and then coming back, sometimes with a bang. As far as the variants that we've kind of seen and dealt with so far that have been of concern, the Alpha, the UK variant, Beta from South Africa, Gamma in Brazil, and now Delta, which are classified as the variants of concern, which are the ones the WHO are following, that uniquely make them concerned about their potential infectiousness. All of those, but for the exception of Delta, have essentially waned and nearly gone away. The other category is variants of interest, which are ones that they're watching, but there's not enough data yet to really know which way it's going to go. Two so far to mention: the Lambda variant, which originated in Peru, caused a lot of infections there, but is now waning as it's competing with Delta. And the Mu variant, which does have a collection of mutations that could suggest that it could evade the immune system, but only right now is about 0.1% of infections globally But 39% of infections that are in Colombia, 13% in Ecuador, and in those countries, it is kind of increasing at a consistent rate. So far, when you see these variants mixed together, Delta seems to far outcompete the other ones. And so that suggests to me that if we do see further variants that cause a lot of problems, they're probably going to be descendants of the Delta variant. And I could certainly be wrong, but it seems like Delta really was a seismic shift in terms of the coronavirus's ability to spread to others and potentially evade the immune system. So it reminds me of what happened with the 1918 Spanish flu, where there was a really big shift in the influenza strain, and then subsequent seasonal strains have all been able to track their origins back to that original strain. So I think that we'll probably see something like this, where we see other variants that will emerge and kind of pop up. We have to look at them, but I do think that if we get ones that cause more problems, likely will be descendants of Delta.
Got it. Got it. So it sounds like things to watch, but nothing that's knocking on the door right now. Dr. Page, Dr. Bierman mentioned sort of vaccination and its sort of importance in terms of that. Can you talk about the status of vaccination in Virginia right now?
Sure. And, obviously vaccination is the best way to prevent future infection and the easiest way to help end this pandemic. And so as of this morning, in the Commonwealth of Virginia, 10.6 million doses have been administered to date so far. So that's pretty phenomenal. If we look at the total population of residents in Virginia, and that's going to include patients who are ineligible to receive the vaccine, so 11 years and younger, that total population or that total vaccination rate is 68.1% of people who have had at least one dose. And if we're that vaccination rate will become 60.7% of people fully vaccinated. If we want to look into the adult population specifically a little bit closer, those vaccination rates become 80.9% of adults are vaccinated with at least one dose, and 72.2% of adults are fully vaccinated. So these vaccination rates are obviously changing daily, and we're trending in the right direction. And this is obviously the best way to, move back to normalcy.
With the recent surge, have we seen any uptick in people getting more likely to be vaccinated, or has it stayed sort of on this slow, steady climb it seems like we've been in for a while?
There was a slight increase with vaccination rates once there was that Delta variant surge in cases. So since the Delta cases have declined, we are slowly seeing our vaccination rates decline slightly. However, we still need to focus on targeting our patients that still remain unvaccinated, focusing on boosters, preparing for when we have recommendations for our 5 to 11 age group. So there's still plenty going on. The pandemic is not over, and we still have a lot of progress to make. But I do want to highlight how far we've come since the beginning of the pandemic and the release of these great vaccines.
Yeah, amazing stuff. And we've got Nobel Prizes getting awarded this week, so we'll see what happens. Maybe it'll get honored. So, Alexis, you mentioned boosters. Gonzalo, moving back to you, thinking of boosters, tell us what the current recommendations are and sort of the level of evidence that supports those boosters.
Well, the boosters are best reserved at this time for those who are going to be highest risk of infections or reinfections or even breakthrough infections. And that's really generally for people who are 65 years older, who have chronic underlying medical conditions. And then there's also the subpopulation of those at occupational risk. So that would be certainly frontline healthcare workers, so maybe some industry or service workers also. So the level of evidence is based on some reports from countries such as Israel, where they've had a lot of boosters. There aren't great randomized prospective trials across multiple cohorts to say that the boosters are going to have a tremendous effect. But it seems to be that from the sero studies that we have, individuals greater than 65 years of age have waning immunity over 3 to 6 months, really 6 months, and those would probably stand to benefit the most from boosters. Transplant recipients also will likely benefit from boosters, again, based on waning immunity.
Got it. So I sort of hear different groups in there. So Tyson, maybe moving back to you, should we think differently about those immunocompromised individuals versus, say, healthcare workers or teachers in terms of how we think about outreach for boosters and who we are more aggressive at trying to get boosters into?
Certainly, and one thing that we should just say out loud is that there is some confusing terminology when it comes to how we're even talking about these shots, the third dose. So the CDC considers they consider it a third dose if you're immunocompromised, and that includes people with organ transplant, HIV/AIDS, on TNF blockers, rituximab, hydrosteroids, et cetera. So profoundly immunosuppressed people, moderate to severe is what they call it. This is a population that represents only 3% of our total population in the U.S., but 44% of hospitalized breakthrough cases, so a clear risk factor. But what studies have shown, some small studies have shown, is that for a significant portion of these patients, they fail to make an adequate immune response in the first place. So the third dose is actually considered a part of a primary vaccination series. That's in contrast to a booster, which is essentially someone who was able to make an immune response, but it waned over time. And so you're giving that boost to kind of boost them up. And those are people who 65 or older, 50 to 64 with underlying conditions. And then there's a kind of a lighter recommendation. The CDC said consider for those who are 18 to 49 with underlying conditions. They did the studies like COVIDnet and Vision showed that people with underlying conditions had a higher risk of being hospitalized, but that was more so for people that were at a higher age group, 50 to 64 and 65 and older. And then of course for people that are healthcare workers. So when you talk with the people like Dr. Fauci and vaccinologists, what a lot of them will say is that because we had to design the vaccine rollout and trials to get them out quickly, we weren't able to do it in a way that optimizes the immune response. In other words, if you look at vaccination schedules for things like hepatitis A, hepatitis B, chickenpox, et cetera, they get booster shots, but oftentimes they're delayed by months and sometimes even years. And that's because the immune system matures over time. I tell people it's kind of like a winemaking, where you have wine in a barrel, but it has to mature before you can actually put it in the glass. Similar sort of concept, and you take full advantage when you give a little bit of time for that immune system to mature. So by design, because people were dying and hospitals were overwhelmed, we had to condense that timeline in order to get the data out there quickly so we could get shots in the arms. But a lot of folks think that the ideal dosing schedule should include a booster. So eventually everyone should have a booster, according to people who study this. But right now, it's quite broad, but it does attempt to try to prioritize people that are higher risk.
So if we're trying to communicate that to our patients or maybe our colleagues, sounds like it's sort of initial dose, and then if we're saying Pfizer 3 weeks later, and then for the series, say for the immunocompromised, is it 3 months, 4 months, 6 months? How should we sort of articulate that if we're trying to talk to people?
Right. So I would say for people that are immunocompromised, I would definitely recommend that they get the third dose. And it's recommended to be given 28 days or after you've received your second dose of your mRNA vaccine. So these are people that are very high risk, and they should, unless there's some contraindication, which shouldn't be so if they've received 2 doses already, they should receive it. For folks in that higher risk group for boosters, 65 and older, that was a clear risk factor for those who were hospitalized with breakthrough infections. And, that's exactly what I'm seeing. I admitted someone last night who was 85. And before that, 2 weeks ago, I admitted 2 brothers actually who were in their 80s who had breakthrough infections that were given to them, unfortunately, by an unvaccinated person. So that's a clear risk factor. I think once you move below that, the people who are not 65 yet, but they're higher risk, 50 to 64, that's going to depend on kind of their individual risk tolerance. I think if they have multiple comorbidities, that is someone who's likely going to be higher risk, and it makes sense to vaccinate them. Then for younger people, there's a debate going on in the public health world right now about, is it even necessary for young folks who have a very low chance of going to the hospital in the first place after primary series? Do they need to be vaccinated? So the CDC intentionally designed this to be individual risk benefit tolerance. So if anyone, regardless of what they do, feels like they want to get a booster, it's just a self-attestation and they can go ahead and get a booster. But I would say for us counseling patients, I would focus right now on really leaning into the higher risk folks, immunocompromised, older in age, and slightly below 65, but multiple comorbidities.
Got it. So Gonzalo, let's get back to you. We have some questions from the chat, and let's take one of those now. So the question is about sort of when are we good enough in terms of vaccination rates? So as we think about this idea of population immunity or herd immunity, what is there a number that you're looking for, Gonzalo, or a range that you sort of will make you feel like we've at least sort of gotten somewhat into that population immunity place?
Well, I don't think we'll ever actually be at herd immunity for SARS-CoV-2 infection or COVID-19. I think that's just not going to happen. I'd like to remind the group that the only infectious disease that's been eradicated to date is smallpox. So if we're going for a herd immunity, so to speak, for eradication, I don't think that's going to happen. Our goal should be to maximally really vaccinate as many people as possible, understanding that COVID-19 is going to become a seasonal or perennial virus, much like other things, parainfluenza, influenza, et cetera, et cetera. The frequency with which we get repeat vaccinations, call it a booster or whatever, is yet to be defined because the science is evolving. But eventually, my sense or my prediction is that it will be a virus, much like influenza, which causes a certain amount of morbidity and mortality per annum. Remember, influenza, we can anticipate 45 to 60,000 Americans dying of influenza every year. And that's essentially what we'll have to accept, my opinion, with or something of that nature, except with COVID-19 or SARS-CoV-2. So I don't think herd immunity is really what we're really going for. We're going for maximal vaccination and probable revaccination on a schedule, which is yet to be determined when we understand the science, the waning immunity, those things a bit better.
Yeah, sounds like more to learn. So, Dr. Page, let's move back to you. So, Pfizer has sort of come out with recommendations for boosters, additional shots, whatnot. I think Moderna is working on that. There's some J&J stuff that may be coming. So, how do you think about or counsel people around the idea of mixing two different vaccine types if they're anxious to get a booster?
That's a really great question and something that comes up in practice pretty frequently. And so it's certainly confusing. It's as clear as mud sometimes. So it depends on the option to mix vaccines depending on the situation. And so what I mean by that is, the difference between a third dose and a booster and, where the patient kind of falls into those guidelines. So we just heard from Dr. Bell that a third dose is essentially an additional dose in the primary series for an immunocompromised person. And that's because those patients have difficulty prompting the appropriate immune response due to an immunocompromising condition or medication. And so they need that third dose to provide that adequate immune response. So at the moment, the only time where it's acceptable to interchange an mRNA vaccine is if that immunocompromised individual needs a third dose and that the mRNA vaccine that they originally received is unavailable. So where this frequently is occurring tends to be in our long-term care facilities. So we, back when we had the federal pharmacy partnership with Walgreens and CVS, they went into a lot of our long-term care facilities and they brought one vaccine. But those patients are, discharged, readmitted, they're cycled through. And so now we have a new set of patients in our long-term care facilities that, may need a third dose, but don't have access to the original vaccine. So it's okay, or it's acceptable per the CDC to receive a different mRNA vaccine if they need a third dose due to an immunocompromising condition. On the other hand, when we talk about booster doses, like Dr. Bell said, tends to be for a more broader general public population with, certain criterias. And those are people who had an adequate immune response, but that naturally waned over time. So at this moment in time, the only people who are recommended to receive that booster dose are those individuals 18 years and older who completed their 2-dose primary series of Pfizer and fall into certain categories for their risk of contracting the COVID-19 vaccine or virus. So for people that received Pfizer originally and are indicated to receive a booster, they should receive Pfizer as their booster dose. Those individuals who received Moderna or Janssen are not indicated for a booster dose at this time. We're anticipating that booster recommendations will be forthcoming from the CDC relatively soon. And it would be complete speculation on my part to say whether or not I think recommendations would be about what I think the recommendation would be about mixing booster doses between different mRNA vaccines. So it's, at this time, those are the recommendations, but, things are continuously changing.
In those individuals, you mentioned the long-term care residents that have gotten, let's say Pfizer and then followed with Moderna or vice versa. Are there reports of harm, or is there even sort of a signal out there, or is it just too early to even know?
We haven't heard, I haven't heard anything anecdotally about any repercussions or any more negative side effects. The data, the CDC reviewed the data and they have allowed the interchangeability of the mRNA vaccines. And I believe that they have allowed that with data that they have sufficiently reviewed that it's safe and effective to do that. At the moment, they just haven't approved that for a booster dose yet.
Got it. So we can think of it as almost sort of off-label in a sense.
In a sense, yes.
Yeah. So Gonzalo, moving back to you. So the J&J vaccine, J.J. Janssen vaccine, different technology than our mRNA vaccines. So as you compare and contrast those vaccines and think about boosters, are you seeing that we're probably going to need boosters for J&J, or is it the kind of thing where you feel like they're sufficiently different in how they there's only one shot to begin with? It sort of seems like there's reasons to think that there may be some important differences there.
Yeah, correct. So it's all been an evolving process, a journey, so to speak. Remember, the word on the street when the vaccines came out was the best vaccine is the ones that's most available to you at that time. Go and get whatever you can get. And I think we've learned over this time frame that the Johnson & Johnson vaccine is not only from the clinical trials, but also post-trial data is less effective in preventing infection, severe infection, et cetera, et cetera. So we are now learning that there is waning. The immunity isn't as good, at least in the real world populations. Therefore, it is almost certain that there will be a booster coming or formally announced very soon, actually, for the Johnson & Johnson vaccine. I think the booster timeframe is roughly 2 months after the initial one. Well, that's what I've read, at least in the unofficial reports. Haven't seen the published literature yet in medical journals. But I think that's where we're headed with that also.
Yeah, and both you and Dr. Bell noted in the chat that October 14th and 15th is when some important meetings are coming more. So this is quickly evolving.
So stay tuned, yes.
Yeah. Dr. Bell, let's move back to you because there's a question here. I think also that the chat sort of alludes to a little bit about the utility of antibody testing prior to giving booster shots and whether that's something we should do. You sort of talked about this gray area between people that are higher risk and slightly less high risk, and then maybe the young folks don't even need a booster at all. Would you see antibody testing as helpful in terms of thinking through that?
Not at this point, and there are three main reasons why. So one, while we generally know that having higher circulating antibody levels do correspond well with preventing symptomatic disease and severe disease, we don't have enough information on what that cutoff is. So what level of antibody corresponds to someone that you could say you have a relatively good chance of doing quite well, you don't need a booster, or you're below this level, you do need a booster. We really don't have a sense of that cutoff so far. Second issue is that not all antibodies are created equal. And the tests will detect all antibodies that are made against the SARS-CoV-2 virus. So when you're infected with COVID-19 or you've received the vaccine, you make a polyclonal antibody response. That means you make different sorts of clones of antibodies that detect different parts of the virus. And some people will make immune responses that are fine-tuned very well to crucial parts of the coronavirus around the spike protein, and they work really well. Some people qualitatively aren't going to be as good, but that number doesn't really tell you that difference between the two. And then third, we're kind of ignoring a really big part of the immune system. We all went to medical school and we're knocked our heads against a wall learning about B and T cells. And so measuring, just antibody levels while ignoring the complicated physiology and immune tuning that happens with B and T cells, kind of like trying to evaluate a bicycle, but testing how the pedal works without testing the brake. So you're kind of not getting a full sense of how well it works. And we don't have a great way of testing that B and T cell response. And that's going to become even more important over time because circulating antibody levels are going to fall with any vaccination. It's just a matter, it's just how they work. You can't pump out high antibody levels against all the things you've been vaccinated against because then you actually couldn't carry oxygen. So I think for those three reasons, right now, it's not prime time to test antibody titers to try to figure out if someone needs a booster or not. I would stick with the general recommendations.
Yeah, and the question in the chat asked about the activated T cells. So do we know Pfizer versus Moderna versus J&J, anything about T cells that's at the tips of your fingers? It's sort of a complicated area, I know.
Yeah, so the only thing that I came across was that the Johnson & Johnson vaccine did seem to produce very good B and T cell responses in germinal centers, which are kind of where these happen. I think real world data has played out and showed that you do have less effectiveness in protection from for hospitalization and severe outcomes with breakthrough infections with Johnson & Johnson, at least right now. I think the booster is going to take care of that. The problem with studying this in detail is that it's very invasive. You have to recruit a lot of patients and do a lot of invasive studies on them that are painful in order to really get a sense of these responses. The study that I referenced, they actually did lymph node biopsies to look at B and T cell responses. So it's going to be hard to get like a large population level sort of study where you can really sort of tease this out, unfortunately.
All right, so before we leave vaccinations, Dr. Bierman, let me ask you one more question. So we're about to hit flu season. So tell us what you're recommending in terms of flu vaccination and COVID vaccination. Can we get them together, space them a couple of weeks? How are we thinking through that?
Yes, yes. If you must space them, you can do that too, but you can get them at the same time. So it's definitely recommended. Now, it is true. It is true that the influenza activity in the southern hemisphere, which typically predicts what happens in the northern hemisphere, has been very low. And this is from Australia, from Asia Pacific, from South America. That doesn't mean that influenza is not going to be present. The vaccine, who knows how effective it's going to be? Remember, we didn't have much flu activity last year. Therefore, the predictive value of the shifts and drifts, et cetera, is probably going to be a little bit less this year, but it is still a pathogen of significant concern and public health significance. So absolutely, positively, get your flu vaccine. I think I'm getting mine next week.
Let's line us up, and we got 2 arms and 2 shots. We're ready to go, right?
Ready to rock and roll, yeah.
All right. Tyson, let's move back to you, and we're going to shift to treatments now, and we're going to start with sort of the hospitalized but non-critically ill patient. So talk to us about sort of where we are in terms of thinking about therapeutics for that hospitalized non-critically ill patient right now.
Yeah, great question, because this has been evolving, and there is some recent news about a pill that's been produced by Merck. But for people that are in the hospital, it really does divide between whether they are in the hospital and need oxygen or if they are hospitalized and don't need oxygen. One thing that I will say is that monoclonal antibodies, which were been primarily used and try to keep people out of the hospital, on some circumstances, we have been using it in folks who are hospitalized who have risk factors for not producing a good immune response. So solid organ transplant, high dose immunosuppressants, et cetera. Some of these people, you actually check their antibody levels and they don't have a good response. Those are people who we actually will try to give monoclonal antibodies to. So that's one reason that we might check antibody titers. Outside of that, remdesivir has been very commonly used here in the US. There is some mixed data supporting it. So the ACT trial was the double-blind, randomized, controlled, highest quality sort of trial that showed a benefit. The recovery trial, much larger numbers, but not as great design, did not show a benefit. So it's actually not recommended by the WHO, but is recommended by the NIH and IDSA. So we're using that. If patients are on oxygen, we're using dexamethasone. There's data out of recovery trials showing that there was a benefit for hospitalized patients on oxygen. And then the rest is kind of looking at immune modulation. So IL-6 cytokine that's involved in inflammatory responses. We have a couple of agents that can target those, baricitinib being one of them that was shown in combination with remdesivir and steroids that have some benefit. So we might add that to someone for a little bit of intense immune modulation. That's actually a rheumatoid arthritis drug. That's an oral pill. And then the IV IL-6 inhibitors, the monoclonal antibodies, tocilizumab and cerulumab. Toci is actually on national shortage, so we've been using more cerulumab. These are more for people that are severely ill, so we're kind of out of that non-critically ill patient. The other thing to mention is that anticoagulation was something that we've discussed kind of, from the beginning, because there were reports early on that folks were getting increased clots and strokes and things like that. Generally, anticoagulation has moved away from empiric for critically ill patients, but there is supportive data from the New England Journal suggesting that it could be a benefit for hospitalized, non-critically ill patients. So to sum up, monoclonal antibody, if they have high risk factors for not making an immune response, remdesivir for most, if not all, hospitalized patients, steroids if they are on oxygen, and considering things like tocilizumab, cerulumab, and baricitinib.
So let me ask a practical question, and this may be a tricky one to answer, but we've had this discussion around monoclonal antibodies for some people that were coming to the hospital that we sort of found they were COVID positive, and maybe they weren't presenting with COVID symptoms exactly, but administering the monoclonal antibody inpatient was tricky because of reimbursement and other issues around that. Do you have any tips about how to solve that problem so that we can not be giving it? I think they're 5-digit drugs, at least 4-digit drugs to patients, and having to not get reimbursement for that.
Yeah, I wish I had an answer for it, specifically for inpatients trying to get this. You actually need to open an investigational IND because it's considered compassionate use. And the problem is the FDA requires an IND. Regeneron also requires an IND. So you're kind of doing these parallel INDs, and they're asking for all this paperwork. And at one point, I actually sent a very strong worded email to them that Regeneron wasn't living up to the standards that they set by the former president who received this therapy without it having even been authorized. But that's an aside. I've been very frustrated by that process. I think on the outpatient side, for folks who are high risk for progressing to being hospitalized, who are positive for COVID-19, it's also it's more widely used in that scenario, but it's also tricky to give because IV, you need a facility, you need staff, and staff is hard to come by nowadays, as everyone on this call knows. So I think for that reason, there's been a lot of excitement about molnupiravir, which I'm not sure if I said that right, but it's an oral drug that has some promise. I haven't seen the primary data. A lot of this is just press release, but 50% reduction in mortality or in hospitalization and death. But an oral regimen that could presumably be much easier distributed in doctors' offices and pharmacies, et cetera.
All right, so we'll get to that one in a second. But before we leave the hospital, I want to ask Dr. Bierman if anything he wants to add about the critically ill patients in terms of thinking about therapies and other things that we might want to try or at least consider.
Well, I think that Dr. Bell covered really all the bases there. There's still convalescent plasma that may or may not have benefit, particularly those who are critically ill. But that's, again, not backed by the hardest and the highest quality evidence. So for the hospitalized patients, that's an additional consideration. Last thing, going back to monoclonal antibodies, if I could really briefly, to really reiterate some of what was already mentioned, the delivery of these medications in the outpatient setting, preferably for treatment for mild disease and not necessarily post-exposure prophylaxis, which some people have gotten also. We have set up mechanisms in some of our infusion sites at VCU, but it's still very tricky to coordinate to really essentially connect the dots, make sure that the patient is PCR positive within the right time frame, referred during business hours, which does include the weekends. There's only 2 or 3 slots from 9 a.m. until 3 p.m. So it's a really challenging proposition. It can be done, but it's not one of those it's not a panacea, number one, and it's not widely available, bottom line. It's access issues.
So moving back to you, Dr. Page, other treatments in non-hospitalized patients that you think we should sort of know about and talk about?
Well, the primary treatment for our non-hospitalized patients really are the monoclonal antibodies. They have the most data supporting their efficacy, and there are different types of monoclonal antibodies available for us in the U.S. And so those include Regencov, sotrovimab, and bamlanivimab and etesevimab. Even as a pharmacist, some of these drug names can be a mouthful. And so the Regencov can be given IV or sub-Q. The sotrovimab and the BAM-EDI are both given IV. And so these are really great drugs to be given in the outpatient setting. Interestingly enough, Regencov has been administered in community pharmacies in some of the other states. But going back to Dr. Behrman's point, it is you do have to think through a lot of logistics when you are administering these types of monoclonal antibodies for COVID-19 treatment. Some of the other treatments that are being used with less data supporting the efficacy and safety would be, ivermectin and vitamin C and zinc. So those treatments are still circulating within our health community, but the treatments that have the most support and the most data behind them are monoclonal antibodies.
So let's address the ivermectin issue. I think that's important. Where did that come from? And I mean, obviously, is there a small study somewhere that sort of led to this, or how did this become such a dominant thing?
So my personal opinion is that there's misinformation going out there. Somebody published a study that had maybe some supporting evidence, and then it really just took off through a lot of communication channels. So reviewing the evidence and reviewing meta analyses, there are a handful of studies regarding ivermectin and the prevention and or treatment of COVID-19. However, these studies really have conflicting evidence. They were small samples and they aren't the highest quality of research that the CDC uses to develop these recommendations. So we know ivermectin is an FDA approved drug for the treatment of certain parasites. And so that does not translate over to viruses such as SARS-CoV-2. So ivermectin is not FDA approved for the prevention or treatment in humans or animals for COVID-19. And there have been multiple statements published by various medical organizations such as the AMA, American Pharmacists Association, American Society of Health System Pharmacies. They all published a joint statement strongly opposing the ordering, prescribing, or dispensing of ivermectin. So the use of ivermectin has really blown up and gotten out of hand. And until we have stronger evidence and stronger data, the CDC and FDA are not recommending this for the prevention or treatment of COVID-19.
Yeah, a friend of mine commented when Facebook went down for 7 hours on Monday that may have been the best thing to happen to the health status of Americans in years. So, which is something to say in the middle of a pandemic. So,
and it's sad to say too that we've had increases in the number of phone calls to the poison control center compared to pre-pandemic baseline. So our job as clinicians are to help keep people safe. And so we want to do that the best way we can. And we need to use our evidence-based medicine to do that.
So I dropped a link to a podcast episode that talks about this. And what they specifically identified was when the conservative right, Joe Rogan in particular, did an episode about ivermectin. He brought in these doctors called the frontline critical care something who've been kind of peddling the ivermectin and other sorts of therapies that have not been proven in high quality studies. But after this episode went out, then it really disseminated widely into these circles, and it became kind of a reflex against getting vaccinated because there was this effective treatment. Then it fed into conspiracy theories that we were trying to suppress it. There's even theories out now that the drugs that are being approved or looking at being approved have ivermectin secretly put into them. It's unfortunate. It started from some in vitro studies that suggested that these supernatural doses of ivermectin could have an antiviral effect. But the problem is if you give those doses in humans, you kill the person, which would have an antiviral effect, but not very useful for the person. And that's unfortunate that some people have died, unfortunately, from ivermectin overdoses. But this gets to the notion of having an active strategy for fighting misinformation, because this is worked hand in hand with the virus and become its own pandemic and led to people dying.
If I may add one thing, Dr. Dell, I did send to put a link in there on Molnupiravir on as a preprint data. I just want to underscore that the readers please use all the caution possible when you read preprints. Again, it hasn't gone through the rigorous peer review, which is critically important. And to give you just a recent example of preprint gone bad was the one by Didier Raoul, the French infectious disease specialist, who published that one on azithromycin. And there's beautiful graphs or figures showing how azithromycin prescriptions went through the roof, which it was flawed data. It wasn't well done, and it was redacted. So be careful with these preprints.
Yeah, so maybe let's stick with you talking about this molnupiravir drug. So front page of New York Times, made a splash. As you think about something like this, what do you see as the timeline? Is it now they're going to do more phase 3 trials? Is the FDA going to look at that and approve it right away? Is it going to be something that maybe a year we'll see? It
Sure.
sort of reminds me of also Tamiflu in terms of the way that I'm at least sort of thinking about it. And you're the one that was saying, okay, look, this isn't going away; it's going to stick around.
Yeah.
So is that where we're going to be in a year, you think?
So the first thing I would say is, like, if you recall, not too long ago, pre-pandemic, how do we learn things? Well, we'd go to conferences, we'd read published manuscripts and journals, and then we debate it, and it eventually become part of the practice. Here we're like, hey, there's a new drug. We learn about it in a press release. We don't see the primary data until a month and a half later. You see a preprint which shows in vitro data that molnupiravir is say nucleoside. I think it's an NNRTI or a nucleoside. I didn't read carefully enough the mechanism of action, but it does have some antiviral effect or impact in vitro. My apologies. So it's suggestive that it may work. It is an antiviral drug. It's not an antiparasitic, for example, and there's a mechanism of action that can actually be well explained. Okay, so I think it's promising, and the press release data would suggest that it's helpful in people who are not too sick or not severely ill with COVID-19 to limit or decrease disease progression. It wasn't entirely clear from what I read what impact it actually has on length of stay, hospitalization, and mortality. So that's to be seen. So yes, we need more trials. I would say, though, from my experience or what I've seen so far with COVID-19, there's probably going to be no miracle cure and no miracle drug. As Dr. Bell nicely went through all the different options, along with my colleague Dr. Page here, it's basically you have to choose the right treatment for the right individual at the right time in their disease. And this will be something similar, albeit likely more easy to administer and hopefully with minimal toxicity.
So let me then ask this question of Dr. Bell and then Dr. Page. So are there other promising therapies on the horizon that you're keeping an eye on that you sort of say, okay, well, this is something that we need to know about, and maybe it's a drug, maybe it's a vaccine. Are there other things that are you're excited about?
To be honest, there's nothing that really excites me. I think if this new drug from Merck pans out, or if it works out, then that would be somewhat of a game changer. It's just because of the ease of delivery. Pfizer also has a pill that they are working on in combination with ritonavir, which is a HIV medicine, a protease inhibitor. So I believe they're entering phase 2 or phase 3 trials with that. There's AstraZeneca is making a monoclonal antibody cocktail to add to the mix of Region, Covey, Eli Lilly, and GSK all have monoclonal antibodies as well. And then actually, there is one thing that excites me. Moderna is working on a flu and COVID vaccine combo. So it would actually be one shot that would protect you from flu and COVID. And what I really like about the mRNA technology is that it's very easy to take it from sequence to vaccine. So I think in the case of SARS-CoV-2, the sequence was out within 2 to 3 weeks, and then trials were up within, I think within a month from that point, looking at an actual vaccine in phase 1 trials. So the problem with the flu vaccine is that there's a long lead time right now between making the vaccine and trying to predict where the flu sort of antigen drift is going to go. The Moderna and using the RNA technology might allow us to compress that timeline, which means that we might get closer to the strains that are actually circulating, which means that the vaccine could be more effective. So that would be the one thing that I'm actually excited about.
Yeah, well, and tremendously powerful for whenever the next pandemic shows up too, whether it's Ebola or something. Yeah. Dr. Page, things you want to add about therapies that you're keeping an eye on or hearing about?
Not so much therapies, but what I'm really focused on, especially at the Department of Health, is helping those patients, or reaching those patients to still, start their vaccination series, or overcoming vaccine hesitancy, or really just encouraging and educating patients to, trust the science, trust the data. And so, in my opinion, every single vaccine that's administered as a first or second dose is a win in my book. Trying to increase those vaccination rates is really just going to help us get to the end of this, if there ever is going to be an end of it. But helping people be more comfortable in addressing their concerns and getting the vaccine is the most important thing in my book.
Yeah, so let's dive into that in a second. But before we leave therapies, I do want to ask one last question of Dr. Bierman. And so that's people that have an exposure that are high risk. Is there a post-exposure prophylaxis type of thing that we should be thinking about or doing?
Well, I mean, there's not a post-exposure that's based on most of super rigorous trials or studies, but monoclonal antibodies are approved for a post-exposure for high-risk individuals. Again, the biggest challenge comes into really getting the logistics, coordinating, connecting the dots to get those infusions done in a relatively fast fashion. Doesn't have to be within hours. We're not talking post-exposure like post-needle stick exposure, HIV positive, you need to get the retrovirals in as soon as possible, et cetera, et cetera. But it certainly can be challenging to even get these infusions done up and running within the course of anywhere from 24 to 36 hours, even 48 hours.
Yeah, well, and in pricing, I always sort of think about, okay, risk versus how much do they cost, and I don't know the answer to that. I think that's a challenge.
I'm not aware of any science, or I've not read any primary literature on using a vaccine for post-exposure and what sort of a response you get. It usually takes a couple of weeks, and we know it takes a couple of doses. So it doesn't seem that the vaccine would be the immediate path forward for post-exposure prophylaxis.
So let's move back to this topic of vaccine hesitancy and how to have those conversations, how you are all approaching that. And so, Dr. Page, let's start with you. You've been thinking about vaccines probably endlessly for the past year. So how are you now approaching those people that are hesitant? What sorts of hesitancy are you seeing, and how do you work through that?
So there's been a lot of research out there as to what strategies are the most successful, and I think the strategy is going to depend on the patient. What's been really helpful is taking that presumptive approach. So when a patient comes to clinic, or when a patient comes to the pharmacy, just presuming that they're there to get the vaccine, and instead of putting it in their court as to say, what do you want to do about the vaccine? Do you want to get it? Just saying, okay, we're here to get the vaccine today, or like, okay, we're going to do this. And then that kind of, then they can take the time to pump the brakes if they choose. Something else that, works really well is motivational interviewing. So that can help with having that patient-centered conversation and increase motivation and the likelihood of that positive health behavior uptake. Other things that have been successful or have evidence behind it is making strong recommendations from their trusted members of the community, such as their doctor or their pharmacist. We've had a lot of financial incentives going around the country, and so sometimes that can serve as a motivator too. Depending on if you have that capability in your practice, though, that's probably not a logistical solution. And so things that I found in my practice to be the most successful is having that difficult conversation, rolling with resistance and hearing their concerns, but addressing their concerns. A lot of these patients are in the movable middle. We do have those patients that are set in their ways and believe what they want to believe, but a lot of patients are, just tend to be scared, and they want the information, and they want to, feel like they're making the right choice. And so by, providing that education, always reiterating what you're saying at every single follow-up, that's how we can move. That's how we can move that needle.
Yeah, so let me sort of turn that question to Dr. Bell, and this is sort of going on in the chat a little bit too. this idea if you've got people that are sort of hesitant, or maybe just haven't been asked, or it's not been convenient, and then you've got these sort of staunch anti-vaccine people. So Dr. Bell, how are you seeing that issue, and how are you negotiating that issue?
All right, so I put people into different categories of how the hesitancy manifests, just because there's a diversity of how that happened. And so there's a clear sort of extreme of anti-vaxxer who is just completely against it, and they want to harass you and like make examples and screenshot you and all this sort of things. These are folks that I don't really try to engage that much, unless they're kind of engaging with other people that are in the movable middle, as Dr. Page alluded to. So I pretty much cut them out of the conversation, and I don't waste my time there. There's a larger group of folks who are pre-contemplative, or perhaps leaning against it, but could be moved to that other side, who do have some legitimate concerns. The problem is, if you're engaging them in a very aggressive way, kind of talking down to them and saying that they're stupid and they are, and they're not making a good decision, that generally turns them off and drives them right into the anti-vaxxer sort of territory. So what I found is exactly motivational interviewing, hearing people's concerns, and providing a safe space for people to put their concerns out there. So typically when I'm talking with someone, I ask them, if they've been vaccinated. They say no. I say, well, how come? Tell me a little bit about that. Just like that. And I leave it open-ended and I let them respond. Usually that first sort of response lets me know where they kind of stand, and it kind of dictates how I go from there. I found that using narratives are very powerful to communicate a point. So I share what I've seen in the ICU. I share stories about patients that came around and decided to get vaccinated based on what they've seen. I talk about patients I've taken care of in the ICU. Narrative is a strong way. It's the way that we connect with each other. It's our social currency, really. When we have a good time hanging out with each other, it's usually because we told stories. So I'll try to do the same. And then the other try to do is provide psychological safety for someone to switch over into the vaccine camp. And what I mean by that is, for a large group of people, choosing to still not get vaccinated is just as much about holding the position as it was what made them decide to go there in the first place. In other words, it becomes kind of a cultural identity to stay unvaccinated. So if you actually become vaccinated, you might be one of the few in your community or your family to joke to the other side. And so you might get ostracized. I actually had a patient say to me, I would get vaccinated now, but, my family would, kind of, disown me essentially, because you're going to the libs and all that sort of stuff. And so I think for folks like that, I think the most powerful example are people who they can directly identify with, who made a similar decision. And the best example I have of this is when I was doing a Blue Ridge Health District vaccine clinic that was on Cherry Avenue. And, I was trying to do my thing, and, I'm a physician, I work at the ICU, I think I'm doing a good job. But then this former elementary school teacher at Cale, formerly known as Cale, now Mountain View, he was principal there for 12 years, absolutely knew everyone in the community. And he was yelling at people from across the street, "Hey, Jarvis, did you get your vaccine? You didn't? Get your butt here and get this vaccine. Come on in and get this." And he was just engaging them in a way that I definitely could not, because I didn't have that connection with them and that history with them. But because he was kind of a paternal figure in the community and had done so good, and people had directly identified with him, he had the authority to say, look, you better get, and it probably brought people right back to the days when he was principal and telling them to get in line. And he was able to convince people to get vaccinated, like on the spot, who were just walking by on minding their business. And he was able to pull people in. So I've started to think about the message and the messenger and trying to customize it for people in certain situations that I think might be the most effective.
So if I may add something, Dr. Dell, I agree with both my colleagues. I think their comments were spot on. Nothing to quabble with there. In my experience working in healthcare epidemiology since 2003, the only thing that's really budged, I'm going to use the influenza vaccine model here, are mandates. And you were seeing that, I think, working now in mass for COVID-19 mandates from employers. airline industry, the federal government, and that's how you're seeing the uptake. Now, I suspect that when we have COVID-19 vaccine approval for children, or it's probably going to be a mandate for public schools, and that'll move the needle on that too. So we will have a hesitant population. Much of that, or some of that, can be further addressed by mandates that are really far-reaching. And I realize they're not particularly popular, but we already have a model for that. And like the public school vaccines is really the model I'm looking for, and employer-based mandates also.
Yeah, well, it's an interesting policy issue, and my experience, taking care of patients in the hospital the past few weeks, we vaccinated a few people, and honestly, it was sort of they just never got around to it, which is fascinating because most of us were probably the first in line when vaccines were available for us. As this is a priority in life, but it's interesting to sort of see some of the barriers or a lot of his convenience and other things.
Remember, with healthcare workers, we were never able to break 60% or so vaccines, and 60% influenza vaccination, incidentally, was considered good before we had mandates. And that's with a lot of cajoling, et cetera, et cetera.
I'm going to push back on one of those points and say that actually vaccine mandates are more supported than they are not at this point. I think there's a lot of support for them. And when there's a vocal minority, but they are actually in the minority, and they're just very loud. They're professionally offended at vaccines in general, and they're very good at it. So I think getting that point across, that this actually isn't controversial when you talk to normal people who aren't shouting in megaphones and screenshotting on Facebook and stuff. But the other thing about, and this was another conversation I had with someone, vaccine mandates actually provide some of that psychological safety cover for some folks who are hesitant to get vaccinated in the first place. So and one person said, this was a cafeteria worker who said, I'm not going to get vaccinated, whatever, that's not for me. You can put whatever you want in your body. My body's my temple, blah, 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 blah. But we came out with the vaccine mandate at UVA Health. And at that point, millions of people have been vaccinated, hundreds of millions. And she had seen that it was safe and effective. And at that point, she was just like, I'll get it. Y'all, I want to keep my job, but I'll go ahead and get the vaccine, whatever. So she got to keep her stance of, you're not going to do this to me, blah, blah, blah. But I still made a choice to do this because you're making me. So for some people who just say, you know what, I don't believe in this, but my job's going to make me do it, so I'm going to do it. There are a lot of people who are in that sort of camp who have the safety provided to still keep their cultural identity or whatever that is, but blame it on the man and go ahead and get their vaccine for that reason.
I think hardcore resistors are going to resist regardless, but the mandate will still move towards greater vaccination across the population. Can't please everyone.
So before we wrap up, there was a question in the chat I want to make sure that we ask before we close. So Dr. Bell, there was a comment about maybe mixing and matching vaccines might be better because you'll get some of this monoclonal antibodies that you were sort of talking about. Thoughts on that, or disagree?
I think in the end, mixing and matching is going to be fine. Specifically, if we're talking about the messenger RNA vaccines, they're just so. I think there's something. Correct me if I'm wrong, anyone, but I think they're about 98% similar. It's basically the same vaccine. The Moderna is slightly a higher dose, actually more of a dose. I think it might be double the dose, at least on micrograms. So that that's a difference there. But I think I haven't seen this NIH mixing and matching study, but I haven't heard any waves about it. So that's probably suggests that it would be fine. Anecdotally, I've known a few people who either intentionally got a different second dose or by mistake got a second dose, and they ended up doing fine as well. So I don't think it'll end up being that big of an issue. And I think after Johnson & Johnson, I think it almost certainly, I agree that that'll almost certainly get approved for on their EUA for a booster, or Moderna. I think they're all going to kind of settle out and be around the same sort of efficacy after they've been boosted and whatnot, and when it comes to hospitalization and death.
I would only add to that, and I agree that the experience that I've heard from my colleagues and I've read, I'm from Argentina. I have an Argentine passport in the U.S., so I follow the Argentine news very carefully. And they are mixing and matching in that country. They do not have the resources that we do in the U.S. In many ways, the vaccine glut that we have here in this country is almost an embarrassment of riches at times. And other countries are mixing and matching, and they're not having any adverse public health reports on that front.
So let's close with this. Realize that the future has been murky throughout this pandemic. We've had predictions that have been off, too low, too high, lots of different kinds of ways. But maybe starting with Dr. Page. So what do you think we're going to see over the next 3 to 6 months?
So I have an idea of what I want to see, and then I have an idea of what we could see. I would love to see a decrease in cases and increase in vaccination rates. My concern is, again, with the holidays coming up and having COVID fatigue, that we may see a spike in cases. And again, that's just my speculation, and I hope that's not the case. And so that's why, education and moving forward is more important than ever right now.
Dr. Bierman, what does your crystal ball see?
Okay, I've been wrong every time, so let me say that up front as my disclaimer. I'm going to take the influenza pandemic 1917 to 19 model. I'm going to say this is going to play out over the course of 2 years. So come March, April, May of 2022, we'll have had 2 years. We will see consistent decrease in rates. There may be new variants and variants of concerns, no doubt. But I'm putting my stock on that we'll have more vaccines. Pediatric populations will be vaccinated, and won't call it a breakthrough, but we'll have additional treatments, including potentially an oral antiviral medication that can help us through the upcoming seasons. So we'll go from pandemic going into endemic after 2 years.
I appreciate the optimism. Dr. Bell.
So I've also been wrong most of the time, so make that a qualifier. But my prediction is going to be that we'll see another wave in the winter. But I do think there'll be more separation in terms of cases and hospitalizations and death. And hopefully that means a lower percentage compared to before of those cases that end up in the hospital. I think that'll reflect the combination of natural immunity and growing folks getting vaccinated. And then I also think that it's going to play out over the course of 2 years or so. And then COVID's eventually going to become endemic, and then we'll have sort of low level circulating with some occasional rises. And then hopefully a low level of people who have severe outcomes over time.
Great. Well, I want to thank all three of you for a very edifying conversation. I've enjoyed a lot. I've learned some things. I know Don put the survey monkey link in the chat there. So if you want to give feedback, that's great. And Don, is there anything else we need to cover? Taking that.
Late unmute. No, just remember those that are seeking CME or CE. That's also the same link that you'll have to complete, just to give your feedback, but then to answer yes, that you do want CME or CE and answer a few additional questions. I'll be emailing that out to all participants who joined by webinar. So be on the lookout for that as well. And that's it for me.
All right. Stay safe, everybody.
All right, thank you.
Bye,
Thank you.
everyone.